Well, hopefully everybody can hear me. Unfortunately, I can't join online, so I'm sort of flying blind here. Um, I, so our presentation today is just around Healthy Minds, Healthy Children outreach and the program that we offer here in southern and central Alberta. If you want to flip to the next slide. I've included a few slides just around Alberta Health Services for those who are not aware of our provincial services here, just to try and help you have a context of where Healthy Minds, Healthy Children fits in the broader scheme of things. So the mission statement of Alberta Health Services is to provide a patient-focused quality health system that's accessible and sustainable for all Albertans. Next slide. Like any large organization, we have our mission, vision, and values. The 7 values that underlie all of our work are respect, accountability, transparency, engagement, safety, learning, and performance. Next slide. This one, I don't know how clear it is for those of you who are seeing it. It is an organizational chart that just sort of gives you an idea of where things, what our organization is set up like. We have a series of what we call health zones, in addition to the higher organizational structure. And so we have the North Zone, the Central Zone, the Calgary Zone, and the South Zone. Edmonton has some of its own organizations as well. Next slide. Oh, mine, I just have to go, I had zoomed in and now I can't see.
So we have it, it's the Calgary Zone.
Right, Calgary Zone is in the map there is that kind of olivey green color, the Calgary Zone, and all of our mental health services are provided under one executive director, and that person oversees both adult and child mental health. Next slide. So our goal within mental health, of course, is to empower people to achieve their optimum wellness. And our mission is to provide evidence-based, accessible healthcare across the entire continuum and across all of central and southern Alberta. Now, how this rolls out varies from location to location, and I'll talk a little more about that. Next slide. In the Calgary Zone, there is a single point of entry into all of mental health and addiction services. It's called Access Mental Health. And when you call in, you will immediately be asked whether it's an adult or a child and adolescent issue. Press 1 for this, press 2 for that. The child and adolescent services are all grouped under child and adolescent addictions, mental health, and psychiatry programs, better known as CAMP. Kind of a long-winded title for all of our services, but everything is grouped under CAMP. When you do call in to Access Mental Health, there is a triage process. There's an intake, sort of a general intake taken right at the initial phone call, and then it is passed to a clinician who calls and sets up a longer time interview, and from there the case is triaged under all of CAMP and a decision made as to where the case should go. Next slide. CAMP consists of more than 70 programs, services, initiatives, and partnerships, and we are managed by 2 directors, one who handles primarily in and day patient programming, and the other who handles all of the community and outreach primary prevention initiatives. The last year that we have the stats for 2016-17, we served about 13,000 children. Again, we go from primary prevention through to and including in and day patient. Next slide. So as you can see, I haven't put all of the services here onto this this arrow, but we start out least intensive, move to most intensive. At the least intensive end of things, you have consultation, education, and collaborative services. And we are sort of prior to Access Mental Health. We do not usually get our referrals from Access Mental Health. We tend to get ours from within the community. And then if more intensive services are needed, they then contact Access and move into the greater system. Next slide. So we've been grouped together because of our collaborative and intersectorial nature. There is a little bit of direct client service. However, most of our work is focused on consultation, education, and liaison activities rather than direct client service, which has its pluses and minuses, particularly in rural and First Nations work, because there is so little frontline clinical work or people available. We often are asked to stretch our mandate within Healthy Minds to provide at least some modified ways of working with these rural people. Next slide. So we began as a pilot project in 2003. At that point, there were only 2 people working in the program. And our reason for being at that point was to support primary health care providers, i.e. doctors, within just southern Alberta. But as word grew, the program expanded to providers outside of the healthcare system and includes central Alberta as well. So for those who are familiar with Alberta, we drew an imaginary line, sort of the old David Thompson Health region south of Edmonton, at the location of Wetaskiwin. A line was drawn east-west, and everything below that line is part of Healthy Minds, Healthy Children outreach. And we go all the way to the U.S. border. Next slide. So in 2005, we received a grant from Alberta Health and Wellness Telehealth to provide innovative ways of connecting with primary care providers using online education and telehealth, amongst other means. For those who have never met me, I'm the lady in pink in the larger photo. Next to me is our child psychiatrist, Dr. Alan Donsky. And next to him is one of our clinicians that has now moved on to another position. So we started doing telehealth consultation with very good results in some areas, not so good in others. Again, primarily based on the accessibility of telehealth technology and whether or not it routinely worked or didn't work. Next slide. So our primary mandate is to support and build capacity in any professional in central and southern Alberta including those on all of the Treaty 7 and those Treaty 6 First Nations that fall in our geographic area. So Treaty 7 is made up of 7 reserves, of which 3 are Blackfoot, 3 are Stony, and 1 is Sarcee, a slightly different tribe. And then those of Treaty 6 are primarily Cree First Nations, clustered around the Wetaskiwin northern border of our geographic area. And it's anyone, not just medical professionals, anyone. You could be a daycare worker, a social worker, a psychologist, a teacher. It's anybody who works with children and adolescents who have mental health, addiction, and or behavioral issues. So we encompass a huge geographic area and a huge clientele. Next slide. This is a map of our clinical consultation zone. Each of the colors represents a clinician. So as you can see, we don't have a lot of staff, and each of them is responsible for a very large clinical zone. If you look in the sort of rusty red colored area, you'll see a purple square. That is my area. Being the clinical lead of the program, I don't do a whole lot of the actual outreach work, but I insisted that I be allowed to continue my First Nations work, which is the reason I joined Healthy Minds, Healthy Children in the first place. And so that is the Stoney Nakoda Morley Reserve that I work on. And the other areas are all different people. We have 3 registered psychologists and 2.5-time position of registered clinical social workers that cover all of those areas. The Deep South in the green, we have a First Nations psychologist who is based down there on reserve. She is on the Blackfoot Kainai Reserve, and she handles the Deep South where there is a very large First Nations population. And she's been invaluable in helping us to expand our service into First Nations. Next slide. So how do we build capacity? We facilitate the acquisition and sharing of knowledge, resources, and skills in children's mental health. Another part of our mandate is helping children, adolescents, and their families access services closer to home. So part of our goal is to try and keep kids in their home communities with their own doctors and services, and only move them into one of the larger centers when we have to access some of those more intrusive kinds of services. And we provide service coordination within and across health zones. So if we have a child, say, in Red Deer, which is sort of in the middle of our zone, needing to access services in some other place, we help to coordinate that and make sure that children do not fall through the cracks as much as possible. Next slide. So we have 3 methods of building capacity. We do clinical consultation, we do professional development, and we provide resources. Next slide. So our clinicians work directly with professionals already involved with the child, adolescent, and family. So our referrals come from clinicians themselves or people that are working directly with the child in some capacity. And so we do not take our referrals from just Alberta Health, and we do not take our referrals, like I said before, through Access. It is the person working with those children out there that contacts us for support. And For us, it can be face-to-face meetings. We also consult by email, telephone, and video conferencing. Next slide. So this slide, the picture, you can see the large picture is of our First Nations office down in the Deep South. The lady to the left with the white collar is our First Nations psychologist, Dr. Deborah Pace. And she's conducting a telehealth with a couple of physicians from the Deep South. Our primary care provider retains the ongoing responsibility for their patient or client. We do not take over handling the cases. We do not carry an active caseload, although we may consult about the same child several times, but we do not often actually lay eyes on the child or get involved on a sort of hands-on basis. We have Dr. Alan Donsky, as I mentioned, who is our psychiatric consultation person. Alan also does not hold caseloads, but he will consult particularly with medical personnel around medications, dosages, things like that. And then with our telehealth service, we will do consultations with our entire team, including Alan, and get as many brains going on the issue as possible. And again, that is sort of a hit and miss. Certainly in certain areas of this southern zone, we have a huge deficit in child psychiatry, and Alan is constantly under pressure to actually take on a caseload. But so far we haven't gone down that road. But it is an ongoing struggle, and I'm sure I'm not alone in that. I'm sure a lot of other people struggle with having a lack of psychiatry. And we provide ideas and resources on assessment, treatment, and further services if we feel that they're needed. Next slide. We are available to provide some on-site co-therapy or direct observation. And so we will go into a therapist's office or a school classroom, a daycare, parent link centers, places like that, and do an observation of a child. Of course, this is with written parental consent whenever we are involved directly with a child in that manner. But it is a way of just, again, helping to build the capacity of the people that are working with that child. And we provided a report and recommendations and resources around what we have observed, and help to support the person that called us in to move forward with the child that they're working with. And again, with parental consent, we will facilitate rural client transfers into and out of the larger system. The nice thing about working in rural and First Nations, we can bypass access mental health if we have been brought in to a case that requires hospitalization or movement into the broader system. Once we have been brought in and we have parental consent, we jump over access mental health and can do an internal referral within child and adolescent mental health, which helps to expedite transferring children and youth into the services they need. Likewise, if a child is being discharged from a program within the city and going back into their home community, we can be brought in to help ensure that that child is linked into services back in their home environment, so that they aren't left with nothing when they're discharged. Next slide. Professional development. We provide free child and adolescent addictions and mental health education, and some of you may be aware of our programs. The clinicians provide live or video conference seminars, lunch and learns, workshops, whatever is requested. And then we also have accredited online continuing professional development for mental health and medical professionals, and for educators. And educators is a broad term we use for anybody who works within the school system. So it can even be a custodian if they are the go-to for a certain child within the school and they're struggling to know what to do with this child, they can access our online education. Next slide. So those of us who do and I do a lot of presentations on various topics, as do most of our clinicians. They can be live or video conference. They tend to be case or theme based. They can be focused on theory, strategies, or a combination. They can be didactic, experiential, or a mixture. And they're customized to the consultee's specific needs. So we often will travel out, take our dog and pony show on the road, and we provide all of the audiovisual equipment, the handouts, and everything else. All we ask of our consultees is that they provide us a space and hopefully a cup of coffee. Next slide. For want of a better name, we call our continuing professional development CPD. So this program was a direct result of the initial ask of us back in 2003 regarding supporting doctors out in rural environments around child and adolescent mental health. And this piece of the work has grown exponentially since then. Education is targeting mental health and medical professionals, and it can include certain people such as school guidance counselors, people like that tend to be, you need to have a mental health background to access our CPD. It's free for Alberta professionals. There is a small fee for non-Albertans, and we do have group discounts. We have had groups from various parts across Canada join into our CPD, particularly in Southern Ontario. We've had a lot of uptake from there, a few people from Saskatchewan and a few from BC. So anybody online who would like more information about that, I'd be happy to make that available. They are all online, and so they're accessible whenever you have the time, and you can sit there in your pajamas with a cup of tea and do some professional education. It is all fully accredited for doctors and other professions. So we are right now in the process of having all of the next year's lineup accredited, so that for physicians who find it difficult to get their education credits, they cannot access this and know that it is fully accredited and recognized as professional development. Next slide. Out of that, we had a lot of teachers and educators asking to participate in the CPD training, and we didn't feel it was a good fit because it wasn't targeting an education environment. So we piloted just a sort of one-off in a small population of an anxiety module for teachers, and it took off like gangbusters. Everybody wanted it. So out of that, we secured more funding and came up with what we call MORE, which is Mental Health Online Resources for Educators. It is a K-12 classroom-focused free online service, and it's all mental health for various levels of professional educators. It again, accessible whenever time is available. And we have tried to chunk these presentations down into sort of 15 and 20 minute bites, so that a teacher during a break could log on and do one little segment if that was what they wanted to do, and get their education in bits and pieces that way. And we try to make them strategies focused based on the classroom environment. Next slide. In addition, we will compile information on professionally vetted websites and take a look at them before we ever recommend them to anyone else. We have vetted them ourselves to make sure that they are sound. They're giving state-of-the-art, evidence-based information before we will pass it on to someone else. So it is a way of furthering information on specific topics. Similarly, printed resources. We have a huge library that is constantly being updated on written resource materials that we can either mail to people, hand deliver, or scan and send. We also include in that information for parents and caregivers, because we often get requests from our consultees, like, how do I explain this to mom and dad? So we have a good library of information for parents and caregivers as well. Next slide. Just a few stats about our program. Given that we are a very small group, our total activities, this is the clinical stats. We have 5.5 clinicians, and of those, I am included, so I would do very little. So basically, we have 4.5 people out in that huge geographic zone. And the total activities that they recorded in our last fiscal year, which is April 1st to March 31st, was 2,851. Our total clinical consultations were 1,201. Looking at gender, slightly higher female to male ratio of the children and adolescents that we've worked with. And looking at age, the largest group would be the 12 to 18, although the 0 to 12 population is pretty darn close to that as well. So we do see the full range of children in different stages of their development. Next slide. Taking a look at the number of cases and the overall breakdown, grief and loss is huge, particularly with our First Nations. So those of us who are working on reserve, certainly the grief and loss has upped the number of cases and stats, because it is an ongoing struggle on all of the reserves. Trauma and anxiety are certainly huge. Behavioral issues, and then the other ones, and FASD again, tend to be our primary ones, followed by depression, ADHD, other conditions. Suicidality, again, in pockets, and non-suicidal self-injury. Those are the primary topics that we get consulted about, although we do get other things. Lately, we've had a bit of a bloom, shall we say, in autistic spectrum disorders. Next slide. Looking at our First Nations, we had 572 interactions, individual interactions. And looking at our in-service presentations, we did 181 last year, with a total number of participants of 6,090. So looking at that as one of our primary ways of reaching lots of people is definitely our in-services and workshops that we offer. We hit a lot of people through that medium. Next slide. Looking at our online learning, we've had 710 people registered last year. And if you look at the profession, we have a lot of social workers. I would, more than 50% are social workers. Next biggest is nursing, and people that call themselves counselors, and that would include people that are youth workers and that kind of profession, and psychology. The others are very small. The tiniest little one is pharmacy. We do get some pharmacists logging in onto some of our presentations on child and adolescent psychotropic medications. But the vast majority tend to be social workers who are able to get their credits for their education requirements through our programming in a quick and easy way. Next slide. The education component, the more people, we had 1,024 educators register last year, going all the way from kindergarten through grade 12. And it has proven to be a very successful program. Next slide. Special projects. From time to time, we're called upon to provide specialized services. One program that I developed was called Intervening with Children in Crisis. It is an all-day training for first responders. So how to not further traumatize an already traumatized child. That has been offered all around the province to rave reviews. In 2013, when we had the huge floods in southern Alberta, we got a request right away for some online education, and we put together 3 modules for parents and caregivers, for mental health, for educators, and for First Nations on what to watch for in their children and adolescents, how to support, how to cope. Next slide. When the DSM-5 came out, we were asked by the executive director of mental health to put together some training for all of child and adolescent mental health staff on the changes from the DSM-4R to the DSM-5. And that is all online training, and everybody is required as they come into the services. They are required to complete that training. We have worked with school personnel from across central and southern Alberta to develop a non-suicidal self-injury protocol for schools with some modules and training that is offered. And we are in the middle right now. I'm sitting on a committee for a suicidal ideation protocol for schools, similar kind of process. We hope to have that done by early 2019 and start to roll it out and train people in schools around how to handle suicidal ideation. And then we sit on numerous local, rural, provincial, and national initiatives, such as this one. Next slide. We've also responded to crises. In 2015, we were called by mental health in Blairmore, which, for those of you who know, it's in the Crow's Nest Pass, the deep southwest of Alberta, where they had a father and little girl murdered. And the mental health staff were unable to meet the needs of the community because they were personally involved with this family, as well as with the person who was charged in the murders. And so we got a request to go down and support the community, which we did. Same with the Fort McMurray wildfire. Several of us went north and did support work in response to that. I personally was involved. There were 2 Morley mothers who were sisters who were murdered here in Calgary. Between them, they left 16 children. And so I was called out to Morley to support the community around that and to directly provide some support to the children and adolescents that were orphaned in that situation. The Waterton Lakes wildfire, again, we were called in to support. And Dr. Deborah Pace, our clinician in the Deep South on Guyanai, has been heavily involved in the opioid crisis that is ongoing on the Kainai and the Pagani reserves in the Deep South. And this is one of the situations where we are actually offering some direct service. During the school year, Deb was putting in a couple of days a week, providing direct service to children and adolescents who had been impacted by the opioid crisis. Next slide. This is an example of the kind of work that we do that involves more direct care. Again, it came out of a pilot project. We were requested by our then director, who is now our executive director, to reach out and try and provide a modified shared care initiative in a primary care network medical office somewhere in rural Alberta. And so in 2011, we approached the management of the Foothills Primary Care Network, which is a very large PCN within Calgary and west of the city. And we proposed a pilot for this modified shared care, and they took us up on it. So next slide. This is the town of Cochrane, beautiful mountain view. So in 2013, we identified the need in Cochrane and area, and so it was chosen. They had no shared care options in their rural setting, and there was no child and adolescent psychiatry available out there. And so in 2013, we put together the pilot and piloted it with Dr. Tina Nicholson, who is a general practitioner out in Cochrane, Peggy Schlosser, who is a nurse clinician in that clinic, and myself, together with the PCN and the Healthy Minds Management, to make this thing get off the ground. Next slide. In that same year, Dr. Nicholson, Peggy, and I completed CanReach training. For those who are unfamiliar with CanReach, it is a mini fellowship in child and adolescent psychotropic medications, and it is a 3-day training. We brought it in, we being child and adolescent mental health, brought it in from the States and have been offering it at a reduced fee for any medical professional and or mental health professional to take the training and better inform themselves around medications. And so we have made it mandatory training for everyone in Healthy Minds to participate in that. We've all been trained. And out of that came a consultation service. So any CanReach graduate has direct access to our child psychiatrist, Alan, and the team. And we do regular case consultation with anybody who has graduated from that program. In 2014, we launched our pilot in the Cochrane Clinic. And in 2015, after reviewing all of the stats, we declared it a success. And it has now become a permanent joint program called the Pediatric Behavior Assessment Clinic. Next slide. So the mandate of PBAS, as we call it, is to support family physicians in improving the mental health care of children ages 2 to 19. The model of care is primary prevention. We aim at providing information, informed advice, and skills coaching support to children's teens and their families in the hope of preventing escalation of an issue so that we don't need to, we're hoping not to have to access secondary and tertiary interventions. I presently spend a day every 2 weeks in the clinic with Peggy doing the shared care model. Next slide. When a referral is made, we use a variety of tools to assess and help the doctor come up with a diagnosis. And we also use them as follow-up tracking tools to see where things are at. And we only work with mild to moderate mental health and behavioral issues. We do not take on anything more in depth than that. The children are referred into the larger system if it's a bigger issue. We use a combination of education, coaching, and resources to increase coping skills, and again, trying to keep them in their home community whenever possible. Next slide. This is just a flow chart of how the decisions are made within PBAS. I won't go into it, but long and short of it is Peggy does the initial testing, comes up with things, talks with the doctor. They decide on a course of action. If it is an issue that they believe doesn't really require extra mental health support, that Peggy can just make some parenting recommendations or something like that, she proceeds on her own. However, if it's an issue that they think there's an actual mental health concern that needs somebody with more training, I'm called in, and those children are scheduled in on the days that I am there, and we take it from there. Next slide. So it's not a child and adolescent mental health therapy service. Excuse me, I've got a dry throat here. So we do a short series of education and skill building, coaching kind of sessions, lots of role modeling and that kind of thing. And if that does not seem to help the situation within 2 or 3 sessions, they're referred into Cochrane's mental health clinic, which is a general clinic. They don't have a specialty in child and adolescent. Or they go into other community services for treatment. Next slide. So some stats on PBAS. They had 66 referrals from within the clinic last year. I saw 37 of those. The number of young people who completed the entire treatment that was offered was 44. Of that 66, 16 were referred on to further mental health support, either at the Cochrane Clinic or with signed consent, became an internal referral into one of the larger camp services. The average number of sessions was 2.5, and the maximum number of sessions was 6. Next slide. The age range was 3.5 to 18 years, and we had about 55% male, 45% female. And the most frequent issues were anxiety, ADHD, depression, disruptive behavior, and family conflict. Next slide. So that brings us to the end of it. This is my contact information. Feel free, if there's anything that piqued your interest, you'd like to know more background or how you might get something similar going in one of your areas, feel free to contact me and we'll liaise to try and make something happen for you. But thanks for participating, and if there's any questions, I'd be happy to take them.
Thanks so much, Lindsay. It's such an extensive program, all those different activities in such a large area that you're working with, and building that whole capacity building in the community. I think is I think everybody talks about having to do more with less, and that capacity building is so important, and empowering everybody in the community, the educators, and to do the maybe to make them feel a little bit more confident in the things that seem to be presented to them on a daily basis, that maybe they weren't sure if they had the skills to manage. So wow, what a comprehensive program. So I'll just throw that there to everybody else online and see if there's any questions or comments or thoughts.
One thing I didn't mention is that we are also a sounding board. I have two people out in the Deep South who just sometimes need to vent for their frustrations, and they're encouraged to just pick up the phone, call us, and let go. So,
Yeah.
and we do a lot of self-care in servicing and stuff like that too, because rural and remote is very isolating work, and we try to provide in the best way we can some kind of community for people.
Hi, it's Colleen. That was a great presentation. It was really interesting to see the whole program, how it fits together. I was just wondering, the one that you talked about kind of last about, I think it was the Cochrane program, supporting the family physician to improve mental health care. Is that something you're being asked to expand to other communities or primary care networks?
Yes, we have tried to get it going in several other small towns. For one reason or another, it hasn't gone. The biggest stumbling block is because it's called modified shared care. Normally, shared care would be a clinician working directly with a physician and meeting with patients that way. We call it modified because we have a dedicated professional other than a physician who is doing the bulk of the work, and then the physician is brought in as needed kind of thing to talk about meds or to talk about next steps and that kind of thing, rather than having them use their time to be a part of the actual coaching and all of that. That's all done separate from the physician, and that's one of the reasons I think it works so well, is that it frees the physician up to get the kind of help that the family needs without them having to be directly involved in all of it. They are more of an overseer.
Oh, it seems like a great model. I'm just thinking, I'm from Kelowna, and we have a lot of small communities outside of Kelowna, and I just think, as the manager of the adolescent psych unit, we often get family physicians just calling our psychiatrists asking for some support, kind of on mild to moderate kids, and not sure what to do next, but not necessarily wanting to transfer kids to this level of care. I think something like this would be, having that non-physician support really important.
Yes, and that was our whole aim, and it has been a very successful thing. Also, just the consultation, like our clinicians can go out if a doctor would like, more information, just spend a half an hour with the doctor in their office, providing them the information, and or they can call in and do a telehealth consult with us, just to help them feel more supported and to figure out whether meds are needed or whatever.
Especially when you think of how few child psychiatrists are around. We have the same struggle in BC with access to that. So how do we do it differently? Great presentation. Thank you.
Oh, thank you.
Any other thoughts or comments from? I know, Jennifer, you're up in the north of BC and lots of small towns around there. Does that resonate with you, some of these challenges and programs? Not to put you on the spot or anything.
Not to put me on the spot. No, thank you so much for the presentation. I actually also found it very interesting to see how some of the steps fit together. Unfortunately, I wasn't here for I was on the line, so I was listening but unable to see the slides, just even trying to recall. The first thing that always comes to mind when I see this, and perhaps it was covered and I missed it, is this sounds great. It offers a really extensive service. Is what sort of budget and where else the resources had to be pulled to resource this. Because sometimes we find, even when you're creating great initiatives like this, you're just redeploying resources from other places, right?
Yeah, and Healthy Minds started off as a pilot with external funding. And then as the success of the program became visible, we started to get Alberta Health Service funding on a year-to-year basis. And then it became a permanent fixture of the healthcare system once we were able to prove our worth, so to speak. Same thing with the MORE program was privately funded, and so was the CPD program until they were able to be pulled into the larger system.
Thank you.
All right. Well, we're just about at the top of our hour here. So what I've done, I've recorded this presentation so people like Jennifer, you can be able to view the whole thing later on when it's more convenient for you, and for other people who've missed today's call. And maybe I'll be able to perhaps also post some links to some of the resources and to some of the resources that Lindsay referenced today. I'll work with her to see if there's some things that we can post directly there, and I will send everybody the links to all of the presentation and all the materials. So, and we'll speak to each other again in September.
Excellent. Thanks very much for the
opportunity. Thank you so much.
Thank you.
Thank you.
Bye.